So we now know that hematological toxicity and infectious complications substantially contribute to non-relapse mortality after CAR T-cell therapy. And we recently developed the Carhemotox Model, which incorporates parameters that are associated with pre-CAR T hematopoietic reserve and pre-CAR T inflammation to predict CAR T-cell related hematological toxicity. So in this international retrospective multicenter analysis or follow-up study, we studied the Carhemotox now in the context of infectious complications and also in the context of disease outcomes. And so we looked at a period of 90 days after CAR T-cell therapy for infectious complications, and we graded on a 5-grade scale with severe or greater than 3 infections requiring IV antibiotic or anti-infective therapy or hospitalization. And so what we find is when we look at pre-CAR T factors, we find that only an elevated Hematox score is associated with an increased probability of grade greater than 3 infections. And of the post-CAR T factors, we identified 2 relevant factors. So the first is severe neutropenia longer than 14 days, and the second is an increased duration of glucocorticoid administration. So dexamethasone 10 milligrams or equivalent greater than or equals to 9 days was also associated with an increased probability of grade greater than 3 infections. So when we now specifically look at the Hematox score, we find that patients that have an elevated Hematox score had an incidence rate of 38% for severe infections compared to only 8% for Hematox low patients. And this was particularly evident for bacterial infections. So Hematox high patients had 58% severe bacterial infections compared to only 8% in Hematox low patients. And we found this also on a Cox proportional hazards model incorporating other baseline pre-CAR T or pre-CAR T factors. And another finding of the study was in regards to clinical outcomes, where we find that Hematox high patients had worse clinical outcomes compared to their Hematox low counterparts. So for progression-free survival, Hematox high patients only had a median PFS of about 3 months compared to 12 months for Hematox low patients. And for overall survival, it was 9 months compared and was not reached for Hematox low patients. And so we think that this has the Carhemotox score is not only going to be helpful to risk stratify patients for hematological toxicity, but also for infectious complications, which I think is really important because it implies that we might be able to risk stratify patients into patients who might receive or profit from anti-infective prophylaxis and or early or G-CSF. We might be able to intensify our supportive measures for these patients. And on the other side, that also means that we might be able to de-escalate our supportive measures for patients that are Hematox low, and we might actually be able to treat these patients in an outpatient setting. And I think finally we can also we identified that the Hematox score may be of prognostic relevance, and so this needs to be studied in a prospective manner, but that's an intriguing finding as well.